and talk about our normative work on the screening chapter of our new guideline. Nathalie, you have the floor.
Okay, so good afternoon. So I'm going to present to you the work which is still on progress on the development of the recommendation for cervical cancer prevention and control. And what I will do is I will start with mainly I will discuss the update of what you know or you may know as the Comprehensive Cervical Cancer Control, a Guide to Essential Practice, which is also known as C4JEP. So this is the WHO recommended approach, comprehensive approach to cervical cancer prevention. So that just to show you where we can intervene and what can be the intervention that we recommend. So in red, you've got the curve on the HPV infection with the peak of the incidence right after the sexual initiation, around 15 years old and older. And that's where we want to focus primary prevention with the vaccine, now as it was just described by Susan. But also, you know, there's lots of sexual health education that can be done with adolescents, contraception counseling, so there is a whole package of intervention that need to target adolescents. Then, when the peak of precancer lesion it's about 40 years old and older, so secondary prevention with the screening and early diagnosis. And then in green, the curve for cancer, where treatment can be done and palliative care. So this is the C4JEP that I was mentioning that was developed in 2006 and that has been translated and used in many countries, as Andreas mentioned. And the key messages was on health education as integral part of cervical cancer. Cytology was recommended, and visual screening method was recommended, but only in a very well monitoring setting so that the impact could be followed up. So, and also it was mentioned that the woman HIV positive or unknown status should be managed the same way that HIV negative woman. So Andreas mentioned the guideline review committee and our mandate to develop guideline. And it's important to understand that between 2006 and now, many progress have been done for cervical cancer prevention. In particular, we've got the vaccine, but we've got also new rapid tests, and we've got new data on the use of VIA followed by cryotherapy. So we decided to update this guideline to follow the process. That's to show you in detail the different steps we've got to go through to develop the recommendation, which is scoping the document, having a guideline development group, having the formulation of specific question on which we want to base our recommendations. And this is very important to understand because this question, PICO means persons, the population, intervention, the control, the outcome, and the time notion. And this question needs to be very well developed because this will really represent the base of the recommendations, but also a strategy to do the literature research. So the update of the C4JEP is focusing on health education. It's focusing on HPV vaccine, on the screen and treat approach, and on the recommendation for HIV-positive women of unknown status. The treatment and palliative care will also be reviewed and included, but there is not a systematic review so far done. So health education, I just want to highlight one point which is related to the previous presentation, which is the importance of health education we need to review with regard to HPV vaccine introductions. So these are the type of message we want to really highlight in the guideline, which related to HPV, that it doesn't cure cancer, that it prevents only HPV-related cancer, and some clarification for what the vaccine does or does not. And it's to be mentioned also that this vaccine targeting the adolescent girls, and adolescents represent 1 in 5 of the global population, we need to be very careful on what will be the messaging toward this population. So it's important for healthcare providers who are not necessarily, or immunization staff who are not necessarily used to deal with adolescents, really understand the issues around the adolescents and around their needs. So now I'd like just to focus on the screen and treat approach and where we are at with the recommendation. I won't be able to present to you all the grading table because they are not finalized yet, but I will give you an idea of what will be the recommendation and what will be the new algorithms. So first, the screen and treat approach, in that we have the word treat, and we looked at the specific recommendation for the use of cryotherapy for cervical cancer prevention. So these have been published, and it gives a recommendation on which circumstances you can use cryotherapy for the prevention of cervical cancer. So the first column shows use, and all the recommendations are presented like that. Now, it's not really necessarily very easy to read, but you've got the first column with the context, then the recommendation, then the quality of the evidence, and the strength of the recommendation. And these are very important for program managers, principally the last one. Because even if you have a low quality of your evidence, you can still have a strong recommendation in terms of public health. So you will implement your recommendations knowing that you could have a better evidence to support that. And it's important also to understand, and the quality or the beauty of this process with the question and with the review of the literature and the grading the literature, is that it helps to understand where the lack of research is. So it's very useful also to develop a research agenda that will provide the information you need to strengthen the recommendations or to get the information new recommendations, evidence for new recommendations. So lesion size, what to do with the lesions extending into the endocervical canal, cryotherapy and the technique procedure, the time to freeze, defreezing, the use of the gas. I'm going fast because the time is a bit short, so I can't go in detail in all the... Yeah, but there is a lot to cover. Which provider can do cryotherapy? So that's an important one because that was quite debated in countries. It's not only medical doctor that can perform VIA followed by cryotherapy, so we've got enough evidence now to recommend it can be done by healthcare provider with an adequate training. The use of cryotherapy during pregnancy, and the retreatment of CIN lesions with cryotherapy. So all that is details, and you will have, the guideline also will be available at the one of the booth tomorrow. So in terms of screening, so we looked at all these different screening tests, so pap smear, HPV DNA-based test, visual inspection with acetic acid. We didn't use, in fact, VILI, and we didn't differentiate between a rapid test and HPV, normal HPV test. So you know the characteristic of the test. We know we've got data for pap smear, for conventional cytology, with relatively low sensitivity, but quite a good specificities, but a very complex management because of the needs to have your sample, to get the result from your sample, to have a woman get the result, to get the treatment. So lots of logistic barriers that make that woman are not necessarily not only well screened, but also treated after the screening. HPV DNA test, so with the very good sensitivity specificity, as you've heard this morning, but also they require a good laboratory infrastructure. VIA, which has a reasonable sensitivity and more or less specificity, but which has the advantage of permitting a treatment right after the screening results. So we will see later, but we'll have some recommendation on the screen and treat approach, treatment with cryotherapy right after screening. So the choice of the test and how we introduce the choice of this test in the guideline is really not to have the effectiveness of a state of the unique parameter or indicators to base your choice on. But it's got to have the capacity to reach the population you need to screen. So the test needs to be adapted to where you want to introduce it, at which level of the health system. It has to have also the capacity to permit a treatment. So it's not worth to implement a screening test that you won't be able to follow up with treatment afterwards. And that's really linked with the capacity of the health system. So the recommendations with regard to the age and frequency of screening has not changed that much. It will change, and I will show you later for HIV-positive women. So we agreed that the range still should be the target populations and priority populations should be between 30 and 49. And if the test is negative, the frequency should be every 3 years for cytology, 3 to 5 years for cytology or VIA, and probably every 8 to 10 years for HPV testing. So the current management of precancer is most low-risk setting, and I'm explaining you why we really look seriously at the screen and treat approach. So classically, really, we still see a lot people using screening followed by colposcopy or biopsy, and then based on the result of colposcopy and biopsy treatment. And that's where we know that we lose people because of the limitation of colposcopy, as I was mentioning earlier, when we use cytology, and also because of the limitation of taking the biopsy for the diagnosis, and also the availability of pathologists in country. You take a country like Tanzania, there is one pathologist for the whole country, so if he's on holidays or traveling, that will be quite an impossible mission to get your diagnosis. So all the work has really been focusing on how to get rid of colposcopy biopsy. And there is lots of work that have been done for the last 12 years on the screen and treat approach. So in order to do that, we had to study each of these tests. And what you see on the left hand column is the screening option that we have evaluated, the population in which we've got the evaluation, and the outcome we looked at. So that's VIA, HPV followed by VIA, HPV followed by colposcopy and biopsy, cytology, HPV followed by reflex cytology followed by colposcopy and biopsy. So we had to look at all the different algorithms, and it's difficult to find so of course the team that works on that use modeling methods, because it's very difficult to have the number of cases you need or information for all the cases, and to get to the outcome you're interested, to the evaluation of the outcome we are interested on. It's quite complex matrix because there is a lot, 6 variables on one, 7 on the other, and 2 in the middle with different age group. So it's a complex matrix which has a lot of empty cases, in fact. So the outcome we're interested in was the mortality from cervical cancer, the incidence, the detection of precancer lesion, the compliance to treatment, the coverage with screening, and secondary health benefit of screening. So for the treatment options, so in addition to the algorithm with the screening and the different age group, the different screening methods and the different age group, we looked at which treatment should be done and what was the impact of treatment. So treatment, we looked at cryotherapy, lip and cold knife conization. In the subpopulation, depending on the size of the lesion, the HIV status, the grade of the lesion on histology, the extension of the lesion in the endocervical canal, and the age, more or less 50. And the outcome also was, of course, CIN, but it was also the long-term impact of the treatment, in particular on fertility, on reproductive health, on bleeding, but also on HIV transmission or acquisition. So this is the results of our questions. And so you see on the left column, you can, should HPV or VIA be used to screen? What is the recommendation is screen with HPV followed by cryo and LEAP is better than VIA followed by cryo or LEAP. And the resource is the comment on where we recommend to implement this type of intervention. And the overall conditions, if it's an important recommendation in terms of public health, and if it's conditional, meaning it depends where you are, that you can implement these recommendations. So that's all this has been, and for each of these statements or these questions, we have the grading table, so all the evidence linked to that with the odds ratio and or risk relative. And, but mainly so that's for one intervention followed by the outcome. And then what has been done is modeling exercise, and I will show you in this slide here. Voilà, what we came up with the algorithm. So, these are the simple recommendations. Huh? These are the most simple algorithm you can find. So you have the asymptomatic population that you want to screen, so the woman over 30 years old. So you have either, so it's, in fact, it looks complicated, but it's not that complicated, because look at it as if it was two different algorithms, one starting with HPV on the left, and one starting with VIA on the right. You see? So you've got HPV, the woman screened with HPV, some are test positive, other negative. The women that are negative will be, the screening will be repeated in maybe 8 or to 10 years. That's what we are still looking at the moment. For the test, the one that tests positive, the huge question is to know whether they are eligible for cryotherapy. So that means that you will need maybe a triage test here, and that's the one that we're still looking at, which test and how to use the test. And then if she's cryo-eligible, then she can have the cryotherapy, and then to be followed up as per the every year, and then depending on the result of the test. If she's not eligible for cryotherapy, or she may be suspect for cervical cancer, then she can benefit of the treatment with LEAP or with cold knife conization, and then or she can be referred for evaluation of the cervical cancer. And for VIA, you've got the same type of algorithm: test positive, test negative, cryotherapy eligible or not eligible, what to do also when she's suspected for a cervical cancer lesion. So the huge question here, I don't know how that works, but I will come back to that, is this 1, 2, third line, when you have cryo-eligible with a question mark. So that will be which triage test to use. So for VIA, it's easy because we use VIA. The yellow one? Ah, oui. Ah, be careful, Susan. And here is, we can use, to determine the treatment, we can use VIA to know if the patient can be treated for with cryotherapy or cytology. So that's the type of, for low-level infrastructure, what we will recommend, this is this algorithm, so negative or positive, and then this is the intermediate step with VIA for determine or to monitor, to be able to perform cryotherapy. And then she can be referred for cryotherapy. LEAP, she's still positive at VIA.
Explain the VE step. What is this?
Oh, it's positive, negative. Sorry.
Result positive.
Yes, she's positive. She can be at VIA. She's positive, negative. Then she can have a second VIA to check the result at the secondary level, where she can where the results need to be checked to determine whether she can have the cryotherapy. Here it is the same thing with. Oh, sorry, I think I pressed the wrong button here. So here you've got the same thing with HPV. So here we give the example of she's negative, then she can be retested in 10 years. If she's positive, she can beneficiate of VIA or cytology. If she's positive at VIA, then she can have cryotherapy or LEAP. If she's positive at cytology, then she goes in the normal algorithm for cyto-based screening. And it's interesting, this approach is very interesting because, you know, cytologists and pathologists, they don't like too much that we get rid of VIA, of cytology, but this way you can increase your coverage of screening using VIA and still refer women for cytology for all VIA positive women. And so that's the one with cytology, where you can refer for colposcopy, diagnostic, and treatment. So, what are the criteria for VIA for treatment selection? Should we use in HPV positive women? So it's to rule out the invasive cancer, and we can treat only if clear VIA positive lesions are seen, or if there is aceto-white lesions. So you treat only after HPV positive test, you will treat only the women that are VIA positive, and if the women are not VIA positive, then they are follow-up 1 year after. Okay. Now I'm finished. No, I want to tell you that for HIV seropositive women, so the recommendations are different because we recommend to screen every woman as soon as they know that they are HIV positive and if they have started their sexual life. So we recommend a screening interval of 1 year for the first 3 years, and if each of the screening is negative, then they can, we can screen only every 3 years. The treatment recommended is LEAP, and it's recommended over cryotherapy, but if only cryotherapy is available, of course it's better than having nothing. So I just want, just want to show you that because you will have it in the booth, and it's important, you know. These are the technical specifications for cryotherapy equipment, which will be very useful for program manager to procure cryotherapy through the national procurement system, and we'll have soon also companion guide available, which will be available at the end of this year, on the monitoring and evaluation of VIA and cryotherapy-based program. So with that, I'm finished. Thank you.